Okay, good evening everybody and welcome to the inaugural lecture of Professor Murray Brunt. It's a real pleasure to welcome everybody here this evening. There's many faces I don't know and some faces I do recognise and know, so I will introduce myself. So I'm Professor Pauline Walsh and I'm the Pro Vice Chancellor and Executive Dean for the Faculty of Medicine and Health Sciences. We do have with us this evening as well our Vice-Chancellor, Professor Trevor McMillan, OBE, who is here for the event and will present Murray with a small memento at the end of the lecture. So the inaugurals are a real opportunity for both Keele colleagues and family and the public to understand the work of the professors that are appointed here at Keele. And so we always relish the opportunity to hear the different types of research, education, innovation and clinical practice that people are doing. And not every university has these events, but we certainly feel they're really valuable, and I just love listening to people present the work that they're doing. So before I invite Murray up, I'll just say a little bit about him to introduce him. So Murray graduated from Westminster Medical School in London in 1983. He was appointed a consultant clinical oncologist at the University Hospitals of North Midlands in 1991. And he was awarded an honorary chair in clinical oncology at Keele University in 2014. And the Institute of Cancer Research, London, in 2017. He moved from clinical practice in 2020 to a substantive chair at the School of Medicine, University of Keele, Staffordshire, and we're very grateful to have him following that move. Murray specialised in breast and skin cancer at UH&M and was an academic clinician with a research interest in breast cancer. He's the chief investigator of the Fast Forward trial, which has changed national practice and is influencing global breast radiotherapy. With an international reputation in breast radiotherapy research, he is involved and leads on a number of national and international initiatives. His research career has included many drug trials, which will also be included as part of tonight's journey of breast management over the last 30 plus years, given with a personal slant. So without further ado, I'd like to invite Professor Murray Brunt up to the stage to give his inaugural lecture.
Pauline, thank you very much for that kind introduction. Yes, it's a real pleasure to be able to give an inaugural lecture. And I'm going to do my story of breast cancer as a clinical oncologist over the last 30 plus years. It seemed a very good title when I suggested it a few months ago, but I've realised more recently how large a topic it is. So it'll be a case of going through a lot of things quite quickly and missing some out. I've been involved at the hospital in over 60 breast cancer trials. I'm going to try and show where we were in 1991 and where we are now, mainly concentrating on early breast cancer rather than advanced and metastatic breast cancer. So a quick flick through early years from as a West Country lad in Taunton, on to Westminster Medical School, and there were two particular inspirational people I wanted to mention tonight. And one was Bob Phillips, a clinical oncologist, who inspired me both when I was a student, and it must have done because I went back, I was his houseman, I was later on went back and I was his registrar as well. So he was a great inspiration, and there was a whole generation of oncologists that came out of Westminster, and I think Bob was critical in that. So I'm a clinical oncologist. Well, what is a clinical oncologist? It's what a lot of people might call a cancer specialist. Roughly, we deal with just about all treatments apart from surgery. So the radiotherapy, all the drug treatments, whether chemotherapy, hormone therapy, targeted treatments, immunotherapy. So we deal with all of those. So where were we in 1991? So I commenced in September. Breast cancer mortality, you can see on the blue curve from the 1970s and taken off in the 1980s, the incidence was going up. And there was about 29,000 breast cancers diagnosed in the UK in 1991. The death rate from breast cancer was also slowly going up and will have mirrored that and followed that unless we can do anything to alter it. So trying to remember where we were in 1991, well, we came after the surgeon, after the surgery. In those days, there was no team as such. You were all individual consultants, but there wasn't such a thing as a breast cancer team. We dealt with radiotherapy, so ionizing radiation or photons or X-rays, you might want to call them. I could only go back as far as the picture in 1997, so we were going in, marking the patients up for radiotherapy. The slides courtesy of Andy Maloney, I'm delighted to say is here tonight. So we had it's a bit like the map contours of what comes out of the machine. We were having to put them together in the 1980s, and when I did my exams, it was very much a lot of tracing paper, and you're putting them down and trying to work out what the patient would receive. The patient's body outline was done with a piece of wire, trying to work it out. So things have changed a lot from that. This was in 1997. There were the prescriptions. So again, think of a map contour. So that's the outline of the patient that you can see there. See if I can get the pointer to work. And so that outline came from the wire, and then we put on the isodoses there. Single cuts, and of course, if you're looking at something like a breast, if you went all the way through, it's not the same shape, but you were doing it all on a single cut. So things have changed a lot. So it wasn't really reality. By 1997, but not in 91, we had the ability for the machine, the simulator, to go all the way around the patient and produce CT scans. That was the quality, very poor, very hazy, but we were able to see that the breast tissue was in and how much lung we were going to be treating. This is the area that would be treated. And there I am just looking at the screen on the image to see how much lung, to see if it was safe. So that already was better than it was in 91. Chemotherapy. There was something called CMF chemotherapy that was just about through in 1991. We were accepting it had some value. We had no chemotherapy unit, so we did have a small isolator, which was just a cubicle that was converted, and we stuck our only pharmacist in there, and I'm delighted to see Nikki in the audience tonight, and she'll remember the little cubicle we used to put her in. So one of the first things we did, we raised money, and we had a chemotherapy unit in 93, but we didn't have one then. So the chemotherapy we gave, which we can describe as first generation, and if you give CMF chemotherapy, and there were different versions. There was an Italian version that you gave it for 2 years, if the patient could stand it for that long. There was a 4% benefit. So is that a big benefit? Well, 4 lives per 100. If you're one of the 4, that's big. And there are a lot of patients that you treat. So if there are 1,000 patients, you're saving 40 lives. 10,000 patients, 400 lives. So maybe it is. On the other hand, that means that 96 out of 100 are having chemotherapy with no benefit, either because they're still going to succumb to the disease or they would have been all right anyway. So is it big or not? And I'll come back to thoughts on that. And then tamoxifen. The trials on tamoxifen had just come through and were showing that this daily tablet, a hormone treatment of breast cancer, was offering an advantage. And in 1991, big trials had come through, and we were accepting that it was maybe for 2 years, maybe for 5 years. It was debated. This paper was 2005, so we weren't sure until later. But by 15 years after having your 5 years of tablets, you save about 9 lives per 100. But this is for patients that have hormone receptor positive breast cancer. Most are, but not all. Back in 1991, we didn't know because it wasn't a test that was done. That only came in the late 1990s, so we gave it to everyone. So I started in September, and within the first couple of weeks, there was a letter that came out about a preliminary meeting of a trial proposed called the ABC trial, Adjuvant breast cancer. Adjuvant means the treatment that comes after surgery. Sent out by this man, who's the second inspiration I will mention, John Yarnell from the Royal Marsden. I mean, this was a drug trial with tamoxifen. John's real expertise was in radiotherapy, radiobiology, and he has been the brains behind a lot of the radiotherapy developments of the last 30 years. But he called this meeting, and I took the opportunity, and I think that was a very important decision. There were about 20 of us that went. It turned out to be the first trial that the oncologists did in the Royal Infirmary. It was the first trial that brought UK centres together. So in those days, it was much more little units scattered around. There was nothing coordinated around the country. But it really brought the centres together, and I think that's something we thank the ABC trial for, and it started to generate a trial culture in breast cancer in the country. The trial itself was talking about prolonged, because we considered 5 years as prolonged, then prolonged tamoxifen, so everyone would get tamoxifen, because we'd seen the papers it worked. Found out later it doesn't work for everyone. And they either have chemotherapy or not, in addition, and if they were premenopausal women, you either stop the ovarian function or not, or you could have both. So it added to the literature. The trial itself wasn't earth-shattering. It did add some information, but it's what it did, I think, for the culture. And take your opportunity. So they were looking for someone to promote the trial with an editorial. I put my hand up and got chosen for that. So in '94, that came through. It became an international trial, and we did assessment at the international centres. Almost 2/3 of the patients still came from the UK. And as our hospital, we were the top recruiting hospital in the country. And at the time, the only hospitals that went into trials were the big hospitals. And so to have hospitals outside that, I think third top was Southend. And it was just people that were there at the time. And as well as the patients, I put 52 into a quality of life study, which is very important, but I'll come back to in a second. And then years later, when we presented the results in 2004, we presented them in 2 presentations, one on chemotherapy, one on ovarian suppression. Again, I put my hand up, got chosen. And these sort of things, look back now and say, gosh, if I hadn't have done that, how would my career have been different? Well, who knows? 1995, there was a Calman-Hine report, which was the first time there was a comprehensive cancer report, reorganising cancer services. They started to talk about teamwork, working in teams. It was new, completely new. We had started to do it informally. So locally with Rob Kirby, Terry Duffy, surgeons, Mark Stevens, pathologists, Saba Bajwa, Helen Francis, who later became our first breast care nurse, and me. We used to meet up and start to talk, but it was an informal arrangement. But then it became formal, and it took many years to really get that going. The hospital then decided, as did most around the country, you needed a director of cancer services to coordinate it all, so they found that young lad to do it for 5 years. And so we turn into a team. So this is a picture from probably 7 or 8 years ago, I think. So the core team You can see that the size of it now. There's quite a few dealing with the patients because there's so much involved. And that was the wider breast team. And this is at one of our twice yearly away days when we used to look at policy and change things. And you need a cancer trials unit. And this was before the days of electronics, so it was all paper driven. And of course, we didn't have one. So the quality of life I showed you that I'd been doing, that involved, I put a patient into the trial. So I discussed what we wanted to do, offer them the trial. If they accepted it, I then gave them the quality of life form while I went next door, phoned a trial centre, got their randomisation. Then I came back, told them what treatment we were going to do, took the quality of life and sent it off. And later on, they decided to give some money out per patient for those centres that put it in. So 1996, Marion Evans, who is also here this evening, came up from Bristol, and she had a background as a research nurse. And so I took the opportunity, managed to beg some money, and we got her first year's salary, and her job description included earn the money for your second. So that's how we started our cancer trials unit in 1996 at the hospital. We were separate from the main R&D until a few years ago. We had ways of doing it. Anyone could express an interest in any of the cancer teams. We had a whole range of trials, these forms showing clinicians to try as an aid memoir. We got national recognition, Mary and I presenting some of our work, and by the time we came into the whole R&D, we were actually employing 14 in our cancer trials unit. So we came a long way. So that's where we were in 91 and the years that followed. So where have we gone from there? So with breast cancer, I've mentioned about hormone therapy and tamoxifen. In the early 90s, another group of drugs came through, something called the aromatase inhibitors. So when you go through the menopause, your ovaries stop producing estrogen, but the body still produces a little bit. These aromatase inhibitors, a once daily tablet like tamoxifen, abolish that little bit of estrogen. And they were found to be active against breast cancer. And the suggestions might be better than tamoxifen. One of the big trials, which we didn't go into, was this one here. So standard was patients took 2 tablets a day for 5 years. So 1 in 3 would be taking tamoxifen and a placebo anastrozole. 1 in 3 would be taking the placebo tamoxifen. And the anastrozole is one of these aromatase inhibitors. Take that. And then, because they had different actions, 1 in 3 patients had both. And I think a lot of us half suspected that was going to be the best one. You've got to do trials because it most certainly wasn't the best one. And if anything, there might be a slight detriment compared to an anastrozole on its own. So there are very good reasons for doing trials and not supposing you know answers. And then 6 years later, this trial shows that there's a 3.3% survival benefit over and above tamoxifen. So we're beginning to add. Most cancer breakthroughs are actually a little gain. You put lots of little gains together, and that's a big gain. We went into other hormone trials. There was this one we went into where you started on tamoxifen, you switched to one of the others, tablets in the 3rd year, and that shows there that by 5 years there was a 3% gain for that. So there were similar trials, and they're all coming up with answers that were not too different. This one we gave the aromatase first, and then you had the option of going to tamoxifen after 2 or 2.5 years. And another one we put into, we had lots of patients on tamoxifen in the early 90s, and then there was a suggestion 5 years, maybe that isn't prolonged, maybe 10 years is a prolonged treatment. And so there was the ATOM trial that we put into, but these are the results, which is the global trial, the Atlas trial, had 20,000 patients, 10,000 on 5 years of tamoxifen and 10,000 on 10 years of tamoxifen. And it did show, and you needed a big trial to show the difference, there is a benefit, but it's just under 3%. So an extra 5 years for tablet for that gain, again, you've got to balance things. Interestingly, if we look here, this is those that took 10 years of tamoxifen compared to data for patients that had no tamoxifen. And this is what we call a hazard ratio. So when you've got this one of a half, that means something's half as likely to happen. So even if you took 10 years of tamoxifen, in years 10 to 20, it was still halving your recurrence rate. So it's having benefit many, many years later. Balances. So you take 10 years tamoxifen, you're now looking at a 12% gain. So if we take our 1,000 women, you've saved 120 lives. However, there are side effects. You lose 4 per 1,000 from either cancer of the womb or blood clots to the lungs. So 120 versus 4 for the population, that's an easy decision. If you're one of the 4, very difficult. So again, you've got to make sure you give all the information. And there are many recommendations. This is the nice recommendation. I'm just showing where we are now. This is not all of them on hormone therapy, but there are lots of different strategies depending on the patient. I mean, so it starts off here. There are men. So for every 1 to 200 women, we see 1 man. So tamoxifen, aromatase inhibitor to the majority, but not for certain reasons. You consider treatment to the ovaries. Can you switch between them? There are lots of reasons for doing things differently. So we're beginning to individualize treatment. Chemotherapy. So the CMF, as I said, was the first generation, but there was a suggestion in the early 90s, a group of drugs were better, the anthracyclines. The first one used, adriamycin, was very toxic to the heart. But there was another one, epirubicin, that if you stayed within bounds, seemed to be a lot better. And so there were lots of trials all over the world. The UK one was called NEAT. So half the patients had CMF, current standard. The other half had this epirubicin drug in it. And essentially, that formed the second generation. And over and above CMF, you've then got a further advantage of another 4%. So you're now 8 to 9% second generation chemotherapy over doing nothing. There was then suggestion that a drug called Taxotere, docetaxel, might have a benefit. Extremely effective drug, extremely nasty drug. So you've got to balance the two. But I think there were 6 of us at the first meeting planning the next generation, and it became the TACT trial. We always have to have a nice name. So Taxotere as adjuvant chemotherapy. It's quite simple, really. Then you switch it round. You can come up with any sort of name. And the treatment there, so this is the new treatment with the green is the Taxotere. There was one of the country was split into 2 different ways of giving the epirubicin, so we allowed either in the trial. And it was one of the many trials around the world that looked into it. Our trial actually showed just about no benefit, but because it was one of 30 or 40,000 patients, you put them all together, and there was certainly a benefit. Some showed a very large benefit. So third generation, overall, there was a 5% benefit. So you're up to about, give third generation chemotherapy, 13% benefit. You've still got 87% who are not gaining from it at all. So if we had a way of identifying who those were, say you could even identify half of the 100 who would not benefit, it'd be 13 out of 50. It'd be a 26% benefit. So if we can get smarter at this, you can increase the benefit from those that actually go through it and stop others having treatment. However, in the States, this was a statement that put out, and that's what some of them followed. Following this third generation trial, they gave chemotherapy to almost every single breast cancer patient. And I know 1 or 2 clinicians in the UK who thought it would be a good idea, but I think generally they got stopped. But that's how some people looked at the data. Seems a little bit hammer cracking a nut to me, because you've got to balance all the side effects. We were getting better and better treatments to control the side effects, but they're still there. As we've got more effective chemotherapy, there were some more toxic effects. So we want to eradicate the cancer, but we don't want to over-treat. And that's what we've got to look at. And then there are a number of things that have started to come through. This is a 21 gene assay on each individual cancer that can be done. I won't go through the details or test you later on those. But we get an answer on something called the Oncotype DX. So for this, you've got two options. You either give tamoxifen or you give no treatment. If your score comes out at under 18, there's a little benefit to tamoxifen, but not a lot. And in fact, some of the very low scores, possibly there's no need to even take tamoxifen. If you're in the middle group, the 18 to 30, there's quite a significant benefit of tamoxifen, so you definitely want to be on it. Moving to the other trial that actually informed this genetic assay, you either had tamoxifen or tamoxifen with chemotherapy. And it was actually only first-generation chemotherapy in this study. And you can see if you look at the inverted triangles there, they are above each other. So if you gave chemotherapy to patients under 18, it would make absolutely no difference to their future whatsoever, so don't do it. If they score between 18 and 30, it makes absolutely no difference to their future at all, don't do it. If they score 31 or over, the chemotherapy benefit, and this is the first generation chemotherapy, is quite significant. So you're beginning to identify who should receive chemotherapy. So if you can find the ones that are going to gain from it, then you can explain, if you have this is likely to make a difference. And it needs to be confirmed. So there's a trial that we were putting into when I stopped clinically, and this is for patients that we decided were to have chemotherapy. So half of them go on and have chemotherapy. The other half, and you don't know who these are, this is done in a blind form once they agree to go into the trial, they're tested. If the result says they're likely to benefit, they get chemotherapy. If it says they don't have it. And the whole lot has a cloak thrown over it. So if they go into the trial and then come back and you say you're going to have chemotherapy, it's to stop people influencing the answer. So they don't know whether you've said they're going to have chemotherapy because you haven't tested them or because you've tested them and they've got a high risk. If they're not to have chemotherapy, then they do know which bit they're in. And so in March 2020, significant for all sorts of things, was when I retired. So my last full month in February, I was delighted to say that we were one of the 2 top hospitals out of over 100 going into the trial, the number of patients we put in that month. And the February recruitment shows the total recruitment, 61. The trust was well ahead. We were the top recruiting trust in the country. So activity for trials, I've always seen trials as a potential benefit to patients. If they want to go into it, you might be looking at the treatment of the future. So give the opportunity. With chemotherapy, I'm going to mention something called the HER family of receptors. So you've got, if you imagine this is a cell and this is the cell membrane, you have these oncoproteins poking out, and this is HER2. There's 1, 2, 3, and 4, but HER2 is the big one that's had a lot more said about it. And when they get together and couple, like here on the surface, what they then do, they trigger a process inside the cell, and you've got a fast-growing, aggressive cancer cell. What trastuzumab, an antibody, or Herceptin as it was better known, shown here by the little yellow Y does, grabs onto the HER2 outside the cell and stops it doing that. So it targets specifically the HER2 protein. And 15 to 20% of breast cancers are HER2 positive. So you would be aiming for those. And this was our first big foray into a commercial trial. So there were 3 trials of Herceptin in the world. 2 were in North America, and the other one was known as the HERA trial, mainly European, but it was elsewhere in the world as well. So the patients had their surgery, chemotherapy if they were going to have it, radiotherapy, And then if they wanted to go into the trial, they were tested. And if they were found to be HER2 positive in their cancer, randomly, they either got no further treatment, 1 year of trastuzumab, or 2 years. More's got to be better, hasn't it? Later on, we found out more wasn't better. 2 did absolutely nothing above 1 year at all. Again, if you don't do the trials, you don't find out. And then when the results were presented in 2005, a bit later, those who didn't have it were allowed to elect to go on it. But there were 3 trials. So the results of the HERA study, the first results were presented at the biggest cancer conference worldwide each year, the American one, late May, early June. And at the same time, the 2 American studies reported as well. They amalgamated results. And here you can see in this blue curve, this is disease-free. So did the breast cancer come back? By 4 years, already you've got 1/3 of the patients who got the cancer back. You give Herceptin, and you about halve that. So we went into this conference with no information on early breast cancer and Herceptin. 4 days later, you emerge with data on 7,000 patients showing an enormous benefit. So if you're in the States, within 2 weeks, you could get Herceptin. The medics wanted to do it. It was driven by the insurance companies being too frightened of being sued for not agreeing to it, so they got it. When Herceptin got a license for secondary breast cancer in 1999 in the States, it took the UK 2 years longer for us to approve it here to get a license. So we suddenly had all this data, and all around the country, oncologists weren't very happy because we had data and we had no way of giving this new and expensive drug. So there were protests. The most active area happened to be here. I might have been a little bit behind it. And I think we're front page on the Sentinel on 270 separate days in some separate form. And so we had quite a campaign going. I managed to get it for a number of patients. You were able to apply to locally, but it was a postcode lottery. And who actually got it and who didn't. Took a year, so that was about the quickest we'd seen. And it's been said to me later that the Cancer Drug Fund, which came through in 2009, which is a process now whereby we do give drugs early in the UK while they're being fully assessed medically, economically, and then the decision finally is made that this and other events around it, but perhaps the Herceptin story was a big part of us getting the Cancer Drug Fund in the UK. So would I do the same again? Yes, I would. It was a very unusual time. But you felt you had the backing of the data. So this is now just showing the 2 getting together, but this is not HER2 with HER2. I think this was HER2 with HER1, but HER2 it really wasn't fussy. It would pair up with anyone on the cell surface. And we've seen that the trastuzumab antibody grabs onto the outside bit, but also it wouldn't do that with the HER1, 3, and 4. But then there's a second antibody called pertuzumab. So here comes our Herceptin, grabs onto HER2. Pertuzumab, it's a bit of a party pooper. It stops the coupling. And so you put the 2 together, and that seemed to be better. And this time data did show that you put the 2 together and it's better. One trial that we put into, one of a number, because we were involved in a number of Herceptin trials over the years, which you had chemotherapy, Herceptin, and either this pertuzumab or the placebo. Already, Herceptin is making an enormous difference. So is it worth it? Just under 2% difference. You need to be able to identify the higher risk patients. So it's not worth it as a general thing. That's too small a benefit. One study we put into, and again we were the top recruiting centre in the country, was EFOS-B, and this was a short burst of Herceptin or a tablet called lapatinib around the time of surgery. Had remarkable results, and it's still in the experimental phase what it may lead to, but it's really just to remind me to mention that things like Herceptin and pertuzumab, what we do now, we get in before the surgeons. So once the diagnosis is made for certain cancers, they have the drug treatment first. And sometimes you find that there's nothing left by the time you have the surgery when you look under the microscope. So there are different reasons. And NICE recommends chemotherapy and Herceptin and others. Again, this is just a few of the many options on the website. So we've got different ways of tackling the patient. It's not one size fits all. We then got a new cancer centre. We moved down from the Royal Infirmary, so after 18 years I had to train the car not to turn up the Queen's Road and go to the infirmary. And already the radiotherapy machines have started to be replaced, and so it's a modern linear accelerator. They really are remarkable what they can do. I'm going to talk briefly through a series of trials where the UK leads the world, and it's particularly these ones here at the top. The START pilot, which was John Yarnell starting in the 1980s, who I showed you earlier, but then the UK-wide START trial, fast forward, when we're looking at reducing the number of treatments. So you give radiotherapy, the standard was, back then, 25 treatments daily over 5 weeks, plus another 1 to 2 weeks if you were going to give extra dose to what we call the boost site. So you could be having up to 7 weeks of daily visits to radiotherapy. We can do the trials because of the NHS. If you're in a country where you get paid per visit, they had no interest at all in these trials. In fact, there was quite a bit. John Yarnell had a lot of difficult time at conferences. People were really not happy as what was happening there. And then we're going to talk a little about breast dosimetry. Do we need to treat the whole breast? Do we need to escalate for high-risk patients? So I'm going to very briefly go through these. And the hypothesis that John produced is that breast cancer was as sensitive to the size of each dose that you give as the late reacting normal tissue. So you're thinking about side effects. And if that's true, because there was a move to go with lots and lots of little treatments, and in some countries they were thinking 5 weeks isn't enough, we give smaller treatments over 7 weeks and then a boost. And so if that's the case, we don't need to give as many as 25. Just to show you some of the more up-to-date pictures, if you compare the ones that I showed you from 97, on a single cut, you can see the shape of this breast. Well, it's not a regular feature. I mean, the perfect patient would be a cube because they're easier to treat, and I haven't yet found one of those. And if you imagine at different levels, there's different amount of tissue that you're trying to treat. That's a bit like a heat map where you're trying to get the dose where you want it, not treat the lung, not treat the heart. The dose is dropping off very quickly. And this is where teamwork in collaboration with the surgeons was tremendous. Because I've not spoken about the many surgical advances over the last 30 years. That's not my remit. But one here where we came together is after you remove the breast tissue where the cancer was, you leave these little titanium clips so that when we come to plan our radiotherapy, we know precisely when it is, where it was, particularly with the techniques now where you're not only removing the cancer, but you're leaving a good-looking result. So you might be moving some of the tissue around, and then we wouldn't have a clue where things were. But they leave their X marks the spot, and our surgeons were particularly good and fast off the mark with that. And so that was extremely helpful. And what they also, and that was driven by trials. So a lot of the trials at the same time, the technique was getting better as well. But when you clear all the glands out from under the arm, they would then leave a clip at the top end of their surgery. So if we were having to treat around there, we'd know exactly where we're going to treat. So instead of marking someone up, you're then looking at the scan to see where you need to treat. You can't see normal lymph glands. So the anatomy that I thought I could forget after medical school and leave it to my colleagues in surgery, I couldn't. You had, because you know where they are in relation to the blood vessels. So you had to know where the blood vessels were to plan out where to give you radiotherapy. And so this is more what we're looking at nowadays when we're putting a plan together. So it's much more complex, much more accurate, and we know what we're doing. And one particular development I will mention, which we now do when needed for any left-sided breast cancer, because that's where the heart is, apart from one patient who threw us all, and Linda will remember that. In the 1990s, she had dextrocardia, and she got to her late 50s and never had a chest x-ray and didn't know. And we looked, there's no heart, but it was on the other side. So apart from that one, that here, so this is the standard treatment, but if you treat in breath hold, so you take a deep breath, chest wall expands, the breast that you want to treat it goes with you, the heart stays where it is. So you've now got a nice distance. So you treat in 20-second aliquots, you treat the breast while the heart's nowhere near, and that way you save the heart. You're reducing side effects. So a lot of what we do now is to reduce side effects. So the studies that we did, the START trials, they had two bits to it. There's our 3-arm study, your standard, and 2 others, and that's because we were able to do some radiobiological work to predict things better, and that's quite unique at the time to the UK trials. And then there was the pragmatic trial, and that's the one we put into, either 25 treatments 5 weeks or 15 in 3 weeks. This was the long-term results. It's what we call a non-inferiority trial, so it's only statistically powered to show that it's no worse. And what you actually saw in the standard arm, after 10 years, 5.5% had cancer back in the breast. It used to be 10 to 20% if you go back to the 1980s, so already that the patient's doing so much better. In the 3-week one, it was 4.3, so that is better, but not statistically different. So we just say it was as good as. A lot of trials are now showing the same difference, so it possibly is a bit more than that, but it was better on the normal tissues. So this came out, the first results 2008. 2009, the UK changed to 15 as standard. There are still parts of the world that are giving 25, and it's unacceptable, but I won't cover that unless you want to in the question. The FAST study, we started the planning that in 2004, and that was a proof of concept trial. Could we even do it in 5 treatments? So we had to keep 25 as standard because that was still the international standard, so we did it once a week. I was fortunate enough to be the one to present the results of the European conference in Berlin in 2009. And then later, which we consider a breakthrough, the 10-year formal results in America. And there's a lot of the Americans and the academics are completely sold by this work now. So a lot of America has moved quite significantly. And we published the results in 2020 of the 10-year results. And again, 3-arm trial. So you've got your 25 treatments, 5 treatments once a week. And then because that was just proof of concept, we do use that regime sometime for a frail patient who often the carer says, I can't come up more than once a week. So come up once a week for 5 weeks. Then the big trial is the Fast Forward trial. And it happened to be, as the pandemic hit, we were ready to start analysing our results. But normally that's a process that it takes many months, you get ready and then you submit. And so my early retirement was nights going to 1, 2, 3 a.m. while myself, John Yarnold, and statistician Joe Haviland tried to knock this into shape in well under a month. the Lancet agreed to fast-track it, but only fast-track a decision, make no shortcuts as to whether we could get it through, because this would reduce the footfall. If you only had to come 5 times a week, 5 times for your radiotherapy during the active part of COVID, I mean, what an advantage. And it showed that that came out end of April, by June, 70% of radiotherapy in the UK across the board had been given in 5 fractions. So it actually speeded up the whole process. The pandemic did have an advantage, but it wasn't about the pandemic at all. And the coordination we saw with the ABC trial, we had 4,000 patients to recruit, and we were given 4 years, and that was considered quite hard. We had almost 100 UK centres, and we did it in 2.5 years. That's the sort of coordination we have now in the UK. The recurrence rate, 2.3% in the breast now at 6 years, so it's coming down and down, because everything's getting better as part of the treatment with the 3-week one, just 1.5% in what we now give. And the following year, we published more data on subgroups. A lot of people saying, well, it's not safe for those at high risk. Well, grade 3, this is not statistically significant. There were 20 recurrences with 3 weeks, only 8. And perhaps the most aggressive, the triple negative, we saw only 3 recurrences and against 10 in the 3-week arm. At the same time, the import trials, we've always treated the whole breast. Well, for lower risk breast cancer, do we need to? So that's the whole breast, forget the middle arm. We're treating the same dose, but just a portion of the breast where the cancer was, and cut to the chase there. 1.1% recurrence at 5 years in the standard arm, and for the partial breast, it was just 1 out of 200 patients at 5 years. We're not claiming that's better. I think there's chance comes into play. It's helpful that it's a better figure, but I would say no more than that. So it's certainly not inferior. And then import high, and the formal publication came out last Thursday. So we're very much where we are now. And that's looking at the very high-risk breast cancers. We're looking at dose escalating the boost and giving it in the 3 weeks. So instead of having your 3 weeks and then coming back for your boost dose, you do it all at once. And you're able now to get different areas in the breast, different doses. And this is the things are looking, so you're treating from 5 different directions in this plan. So it's getting more and more complex. But you're able to do it. And again, we had 2 arms for that. We had the one that we thought would be equivalent, which was equivalent, and then the one with the higher dose, that might be better. It's come out worse. You have to do trials, because you don't get the results you always think. And then we always knew that we'd be able to put the 5 treatments together with the partial breast, and we have. So this led to a meeting in October 2020, with the publications in 21. The UK has now moved to 5 fractions in a week as your full treatment for most of the radiotherapy, not with all. The extra data we produced there. And I've just 2 weeks ago had an article out. I was asked to review the radiotherapy, and I've gone back 50 years and reviewed the whole history as we came through. And what's the safest form of radiotherapy for the patient? Well, it's actually not giving it. So there's a study that's recruited now waiting for the answer. We can identify patients who don't even need it. That's the least damage you can cause. And so that's what we're trying to do with Prime Time. We're fairly sure they're out there. Past trials have tried to do it. They've never identified the patients well enough. But with current pathological markers in the lab, we think we might be able to identify low enough risk patients you can say, you don't even need any. So where have we come then? So those are the trials that we have looked at. We're going to go forward now, and we've just submitted to the NIHR for what we call Fast Forward High. So Can you produce like that import high where you do it all in 3 weeks, where you don't come separately for a boost? We're going to try and see if you can do it all in a week in 5 fractions. It's already including patients having treatment to their arm. The most difficult area to treat is what we call the internal mammary chain glands behind the sternum, because you're having to go so deep. It will include some of those patients. It'll be enough to answer the questions. So we should be in a position, if we get funding, and funding is a problem for all studies at the moment, to answer those questions. Just as I wrap up, a cautionary tale. We were approached some years ago to see if we wanted to be involved with the first ever breast cancer vaccine that had gone into phase 3 trial. Sounded great. This was the data from the phase 1 and phase 2. It was all from a single centre in the States, but it looked very encouraging. Sounds great. These are patients who've had breast cancer and you're trying to stop it coming back. Seemed like a really good idea. Wonderful slide I could put in talks, and there's a whole load of slides that came with it. The clever mechanism of action. And suddenly we get a phone call one morning to say the trials stop. It's futile. That the results were not going to show anything positive. So you have to do the trials because you don't always get what you're expecting. So yes, we knew that could be the result. Didn't expect it, but that's where it went. So apologies to the many studies and treatments that I've not mentioned in the interest of time, such as antibody-drug conjugates, immunotherapy, which is becoming big for triple-negative breast cancer, trial drugs, some of which will make it to the clinic, some won't. Group of drugs called the CDK4/6 inhibitors, which is enhancing the hormone therapy. And so where have we ended up? Well, this is the graph I showed at the beginning, but the rest of it now there. So the incidence, we were 29,000 in 1991. 2 years ago, there were 55,000 breast cancers diagnosed in the UK. The mortality, and that's the overall rate, has not gone up to mirror it, which it looked as though it might, because of everything, screening, better surgery, all the treatments you've seen, better awareness, all sorts of things mean that despite the fact we've almost got twice as many patients, there are far fewer deaths from breast cancer than there used to be. You can only go up here because you've got to follow it for a few years, 2012 and 13. And then I had the talk all sorted out, and then this morning the BBC points this wonderful latest study that the Oxford Overview group published yesterday. And Caroline Taylor, who is a clinical oncologist, Caroline's done a lot of work over protection of the heart, has produced this. And what this shows, and I've just put this one slide from the formal paper, so mid-90s, this is the mortality rate. 5 years later, far less. 5 years later, and the latest one, because their data goes up to 2015. So at 5 years, all patients with breast cancer, the risk of dying is just over 4%. In the mid-90s, by 5 years, that was over 14%. And this is those thought to have early breast cancer. So we are seeing a lot of improvement. They've looked at all these factors here, which means my next slides are relevant because they've just shown all that. So it's been a privilege and a pleasure to be involved in some small way in the last 30 plus years of patient and breast cancer management. And thank you very much for your attention, particularly on this hot evening.